Hello. Here we are with Ask Me Anything for September 4th. Got a bunch of questions today, so let's get into it. Margaret says, "Hi Raf, I have a question for you. I have a fit client in her 40s who can't do the supine Pilates mat exercise, the roll-up. I noticed that she's unable to articulate her spine around the lower thoracic and lumbar area. It just flattens out. Same observation when she does a cat stretch. That part of her spine just flattens and hinges up and down. Seems like the vertebra is stuck. What causes that, or what would you make of this? And what is the best way to help her get more movement there and help her do the exercise? Thanks. Warm regards, Margaret." Margaret, I would start with somebody who can't do the roll-up. Couple of things. First thing I would look at, now you said she's a fit client, so let's look at the things that are required biomechanically in order to do the roll-up. In order to do the roll-up, you need to have the strength in your hip flexor muscles, which are there, and to a certain extent your abdominal muscles, which are here, in order to lift your torso up like that. And so to kind of drill down into that just a little bit more, there are two components to the roll-up movement. There's the flexion part, with the torso flexion, which looks like that. Okay, and that torso flexion is done by the abdominals. The abdominal muscles do that torso flexion. And it happens to be the case that the middle and upper thoracic should look roughly like that. Like most people, the average person, if your client has average mobility, or let's say if she has enough mobility in her spine to do the roll-up, she should be able to roll up until her shoulder blades are almost or just completely off the mat. So if she can roll up till her shoulder blades are off the mat with her lower back on the floor, then she's got probably enough spinal flexibility. So it's the abdominals here that do this trunk flexion. That's the flexion of the trunk. And that is what we would call phase one. I guess, we could call phase one of the roll-up is trunk flexion. And then the second part of the roll-up is hip flexion. And hip flexion, we take that exact same shape of the trunk. So the trunk doesn't change shape anymore from this point. It's maximally flexed. And what we do is we flex the hip. And you can see that all of that movement there has occurred around the hip joint. All of that movement has occurred at the hip joint, and that was what I would call phase two, hip flexion. So, and that is accomplished by the hip flexor muscles, which are all roughly kind of sort of in that region. So if she can do phase one, if she can roll up until she looks kind of like that, with her shoulder blades just touching the mat or a little bit higher off the mat, then if she can do that, her spinal mobility is fine. And conversely, if she can't do it, then you need to work on her spinal mobility. But if she can do that and then she can't get further, well, then what that says is it's her hip flexor strength that is the problem. So you need to work on hip flexion strength. And, well, the best way to do that is in a movement that is as similar as possible to the one that you're trying to improve, which is the roll-up. So I would start maybe a little higher in the roll-up. So you could start, where would you start? You could start here. She could start here, hinge back like so, and then round her spine and roll back. Okay, round her spine and roll back, and then she could roll all the way back down. Okay, and you could do that, basically what we would call a negative rep or an eccentric rep. It's the lowering phase only. So she could do that. Or she could do the full exercise with some kind of nifty flex band around her feet to help her pull up, and that will reduce the load. That will help her, will reduce the load on her hip flexors and her abs a little bit, and she can do kind of a bicep curl at the same time. Bicep curl, and we'll put the band going up to her hands there, and that should help her get up. And the third, so those are the two possibilities that kind of seem most likely to me based on what you've told me, is that either her abs are not strong enough / she doesn't have enough mobility in her spine, or her hip flexors are not strong enough. Now, if she doesn't have enough mobility in her spine, how would you work on that? Well, stretch her spine. And the way you can stretch her spine is basically, if we look at this roll-up position, okay, here's the end position of the roll-up. Okay, well, if we take that position and we flip it, what exercise does that look like? Well, that looks like the rollover to me. So, and in the rollover, it's awesome because you've got all of the weight of the lower body stretching out the spine. And I'm sure if you've done the rollover, you've experienced that. So I think the rollover is a fantastic exercise to stretch out the spine. If she can't get into the rollover, you can start her on a prop, just a bolster or a cushion or an ottoman or something. You can start her like that with her feet like so, and that will help her kick her legs over quite easily and get into the position. And if she gets when she gets towards the end position, she finds it too strong of a stretch, you can prop her at the other end as well. So you can put a prop here, a chair or a sofa or an ottoman, something that's at the right height, so that her legs don't have to go all the way to the floor, and you can make that whatever height you want to make it. In this prop here, you could, make that a much bigger prop, and so her legs don't go that far, basically until she feels a stretch in this, area here and somewhere in her lower, mid, or even upper back. So those are the first two things I would suggest. And the third possibility is as she goes to raise up, her legs come up like that, and it looks more like kind of a teaser than it does a roll up. In which case, it's a very, very simple solution. Just press down on her feet or get her to do it with her feet under the sofa, something like that. And this is just a simple matter of biomechanics, not strength. So if you have somebody who has a relatively light lower body compared to a relatively heavy upper body, okay, and their upper body might be heavy because they hold fat in their upper body, maybe they're an apple-shaped person, or it might be heavy because they have a long torso and short legs. It might be heavy because they're muscular. There are lots of reasons why someone's torso might be relatively heavy compared to their legs. Now, it's just a simple matter of physics, right? If you've got a pivot point there, and you've got more weight on this side, well, you're not going to be able to roll that way. Like if you have a seesaw here, okay, and you put 10 kilos on that side and you put 6 kilos on that side, this side's going to go down and this side's going to go up. So if you've got 6 kilo legs and a 10 kilo torso, you're not going to be able to do the roll up unless you have something holding your feet down. So I hope that helps, Margaret. Let me know how you go. Next one comes from Teal. She says, hey, Raf, just a quick question in regards to the recipe we went through in this week's diploma lecture regarding ACL or anterior cruciate ligament rehab. Is that something you would have on hand in the studio prior to the client coming to see you, as I'm guessing you won't always know what their issue is, as part of their initial assessment, or would you look for it after the client has been to see you and then go through it with them after the first session? So, Teal, I would the way I would approach that is basically when anybody books a session, I would create some kind of process where you ask them what do they want to work on. So example would be, if they booked by email, you just have an email template that you use that just says, can you tell me about what you want to achieve, through our sessions? How will you know that our sessions together have been successful? And that way you'll get the information. The other thing you can do is ask them and at the same time, ask them to to send to you a copy of any information that they would like you to have on the day, so that you can look at it beforehand and you can study it. So typically I would ask people to send through any scan reports, referral letters, doctor's opinions, etc., like that, things that they feel are relevant that they would like to share with you. So you could do that in an email template. It's very simple to create a little online form using something like Google Forms as well, where people can submit that and just send it through to you as an email. And if you use a booking system like Mind Body Online or Acuity or something, you can also put a space there for notes where people can tell you about stuff. So that would be my recommendation, is anytime someone comes to see you for the first time, ask them to tell you beforehand, when at the time of booking, what it is that they want to work on, and to send you any documentation. And then, I just keep that on my laptop. I keep a digital copy of it. So you keep it on your laptop, on your phone, etc. And just, that way I would always have, if I was you, I would always have your laptop around when you're doing a session, so you can look stuff up on the internet, because you're going to need to. I hope that helps. Valida says, hi, Raphael. I've been enjoying your Ask Me Anything. I've learned a lot from them. Well, I'm glad to hear it. I'm teaching someone who has a damaged C5, 6 and 7. She fell in October 2018 on her right side, but it's her left side that's affected. She has pain in the base of her head that radiates through to her left shoulder, arm, elbow and hand. The pain is pins and needles, and it's constant. They're telling her that if it doesn't get better soon, she'll need surgery, but she wants to avoid it. Is there any good exercise that would help her ease up the pain and help it get better? She can't keep her head up when she lays supine, and that's her goal for now. Thank you. Well, okay, so Valida, just to kind of unpack that a little bit. So the C5, 6 and 7 are the three lowest cervical or neck bones, vertebrae. And the C5, 6 and 7 is where the nerve roots that radiate, that innervate the arms, so where you get sensation in your arms and also signals to the muscles in your arms. They leave your spinal cord, but at around C5, C6, C7, and all of those vertebrae, and then go out to the hands, or every part of the arm. So if there is any kind of issue at C5, 6 and 7, that can result in symptoms, whether that's pain or altered sensation or muscle weakness, suppression of reflexes. So if you've ever been to the doctor, sometimes they test your reflexes by hitting in the elbow with a little rubber hammer, and it makes your arm go like that. So that's testing for the function of the nerves. And if the nerves are functioning normally, you get a normal reflex. And if the nerves are not functioning normally because there's some kind of problem at C5, C6 or C7, then you get a suppressed reflex. Valida has a question. She says, "Hi, Raphael. I've been enjoying your Ask Me Anything. I've learned a lot from them. I'm teaching someone who has a damaged C5, 6 and 7. She fell in October 2018 on her right side, but it's her left side that's affected. So the C5, 6 and 7 are the three lowest cervical vertebrae, the three lowest spinal bones in your neck, and the nerves that exit the spinal cord at C5, C6 and C7 feed your upper shoulders and your whole arm. So if you have a problem with the nerves in the C5, C6, C7 region, you can have altered sensation in the arms, because that's where you get the sensation from. It goes through C5, C6, C7. So you might feel pain, you might feel any kind of weird altered sensation in the arms. Also, the motor nerves that come through those spinal bones, C5, C6, C7, they innervate all of the muscles of the shoulder and the arm. So they send the signal from your brain to the muscle to tell the muscle to contract. So if you have a problem in your neck at that level, C5, 6, 7, you can have weakness in the arm because the muscles don't get the signal properly from the brain. And the final thing you can have is suppressed reflexes. So when you go to the doctor, sometimes they test your reflexes, and you may have seen it done in the knee where you hit the kneecap and your leg kicks up. Well, you can also do it in your elbow. So there's a tendon reflex there that if the doctor hits you with a hammer in just the right spot, it turns that muscle on, and that tests that your spinal, your nerve is functioning correctly, like the signal is getting through from the spinal cord to your arm. And so if you get a suppressed reflex, like a really little, weak contraction when you hit the arm compared to the other arm, that can be an indication that there is some compromise to the nerves, like maybe the nerves are being irritated or impinged, or they're not functioning correctly. So all right, so I'm teaching someone who has damaged C5, C6 and 7. She fell in October 2018 on her right side, but it's her left side that's affected. She has pain in the base of her head that radiates through to the left shoulder, arm, elbow, wrist and hand. The pain is pins and needles, and it's constant. They're telling her that if it doesn't get better soon, she'll need surgery, but she wants to avoid it. Is there any good exercise that will help her ease up the pain and help it get better? She can't keep her head up when she lays supine, and that's her goal for now. Thank you. Well, Valida, a few things strike me about this. Now, I've got kind of limited information here, so some of the fair bit of this is going to be guesswork, but I did spend about an hour on Google Scholar looking through systematic reviews and randomised controlled trials on what this is called cervical radiculopathy. Cervical means neck, and radiculopathy just means there's some pain or symptom that is related to nerve irritation. So it is the case, like I said a minute ago, that damage or compromise to the nerves at C5, 6, 7 would cause or could cause the symptoms that you describe, pain, pins and needles down the shoulder and the arm. But not the pain up to the head. So right up to the head here, that is C1, C2, C3. C5 is kind of down here. So, and the nerves that come out from C5, 6 and 7, they go down. They go down the body into the shoulder and into the arm. They don't go up the neck. So any kind of problem at C5, 6, 7 wouldn't be expected to cause pain going up the neck into the head. It would be vice versa. If there was pain, if there was a problem with the nerves at the top of the neck, that would cause pain going down the neck, typically. So it seems that to me that's a little bit incongruent, and so the symptoms don't really fit the diagnosis of damage to C5, 6, and 7. They partly do, but not completely. Also, she fell on her right side. It's her left side that's affected. To me, that seems a bit weird, unless she fell on her. I can't really imagine how she fell. You don't say whether she landed on her hand or whether she landed on her shoulder or whether she landed on her head or whether she landed on, the back of her head. So I can't quite imagine how she could fall on her right side and that could damage her left side, but might be possible. And the pain is pins and needles and it's constant. So that is consistent with some kind of issue with a nerve root at C5, 6 and 7. A nerve root is just where the nerve comes out of the spine. In fact, I can show you that. So here is the cranium. That's the bottom of his skull. And this is C1 up in here. C2, C3, 4, 5. That's C4. That's C5, C6, and C7. So, and I wanted to show you the nerve roots. And the nerve roots are these little yellow things that you can see sticking out there. So those go out and they go down, form nerve tracts that go down your arm or shoulder or wherever, and bring sensations up to your brain from your arm and hand and send motor commands, commands to the muscles from your brain down to your shoulder and arm. So if there's a problem with the nerve root at C5, 6, 7, it is consistent with the arm symptoms, and the pain in the neck and the head might be a separate symptom. And so I guess that's my first thought is, that diagnosis, based on the limited information that I have, seems a little sketchy to me. So maybe there are other parts to that. And for her to have been diagnosed with radiculopathy, they would have had to do a full neurological exam. So they would have to test her reflexes and muscle strength and stuff in the arm, her sensation. They poke her with things so if she can feel it, etc. So, and they probably would have to do an MRI or a CT scan of her neck to determine whether the nerves were being pressed on by any structures, a disc or bone spurs or anything like that. All right, so there's that. And then the second part of the question is, what can you do to help her? Well, the prognosis, the natural history of cervical radiculopathy is actually very good. So typically something like 83% of people have significant improvement or resolution of symptoms within 36 months. So that's 3 years. So she's your client is, you said, October 2018. We're now in September 2020, so she's almost at 2 years. So I would say just like steady as she goes, at least for another 13 months with her. There are very limited studies looking at exercise and very few studies looking at comparing exercise or non-surgical interventions to surgical interventions. Typically, the surgical comparisons look at one type of surgery compared to a different type of surgery rather than surgery versus no surgery. However, there was a systematic review, I think it was from about 2010, from memory, that I saw that examined surgery versus, it wasn't a systematic review, it was a randomized controlled trial from about 2010 that looked at surgery versus conservative care. So in other words, physiotherapy and exercise. And what they found was that the people who had surgery for cervical radiculopathy, they had in the short term, their pain and function improved more quickly than the exercise and physiotherapy people, but that by 1 year post-surgery, the exercise and physiotherapy people, their outcomes had caught up, and in the 2 and 3 year follow-up, there were basically no differences between the two groups. So I would say it's not well established, under what conditions surgery is going to give a better outcome. And I would definitely work on strengthening. I would work on neck strengthening. I would work on arm strengthening. I would work on arm range of motion. I would work on neck range of motion. Anything that aggravates her pins and needles, I would tone down. And if it aggravates it momentarily, but then it subsides, just about straight away, don't worry about it. A little teeny bit of aggravation during the session is probably no big deal. But I would try and avoid things that, significantly aggravate her symptoms. And so just neck strengthening stuff. So, if she can't lift her head off the floor in supine, well, there's lots of things you can do. Proper semi-reclining, at a 45-degree angle. And that's that way less load, so she can lift her head against a lighter load, or get her to put one hand behind her head, or get her to get a little flex band. Little flex band behind her head so she can roll up. But the trick is not for her to not just lift her head using her arms, but to just provide some support. So I guess my preference would be reduce the angle to gravity, put her at a 45-degree angle or whatever angle she needs to be at, so that she can lift her head without the assistance of her hands. The other thing you can do is, if you've got a longer flex band than this, you can put the flex band around her head and then tie it onto a wardrobe doorknob or a table leg or something, and do neck curls. And then you can put it on the back of her head and do neck extensions, and put it on the side of her head and do neck side bends. So you can work all of the muscles of the neck using a flex band, tied around something secure. So that's my recommendation. I would say steady as she goes, and if she exercises consistently and works on her strength, range of motion in the neck and the arm, and if by October 2021 she's still unhappy with the level of improvement that she's had, that's the point at which, if it was me, that's the point at which I would be contemplating surgery. But bear in mind that there is no clear evidence that surgery is superior. It may well be so for some people, but we don't have yet enough research, I think, to be able to define in advance who's going to do well with surgery and who isn't. So I hope that helps. Joe says, are there any Pilates books that go over in more depth what exercises are specifically good for different injuries? If not, maybe you could pull all your research together in a book. Well, I'm not sure if that's a question, Joe, but thanks, thanks for the vote of confidence. I have thought about that. Every time I think about it, it just seems like a whole mountain of work, and I'm not sure where to start. Oops, I forgot to add this question to my one I just sent. What's your Pilates journey? Well, there's a question. So my Pilates journey, well, in my 20s, I did martial arts. I was a mad, keen, obsessive martial artist. That's where I met my friend Heath Lander, who's also a trainer with Breathe Education. We met through martial arts. In fact, Heath wrote a book called The Bouncer because he was a bouncer and I was a bouncer. We bounced together for quite some time. And so I was a mad, keen martial artist, and at some point in the early to late 1990s, I would say, late 1990s, I was up in Sydney, had a martial arts school, I guess you could call it. Really, that's a bit of a over-glorification. It was really just a couple of classes run out at the back room of Newtown Gym in King Street, Newtown, and a few classes in the park, also in Newtown. And just got more and more interested in how the body worked and, the exercise part of the class, the warm-up and the cool-down and the stretching, and noticed that all of my, a lot of my students, probably almost all of them, had some kind of ache or pain. Most of them had some kind of back pain, and just got more and more interested in that, and wanted to include yoga and Pilates in what we did. So wanted to open a studio with martial arts, yoga and Pilates, and didn't really know thing number one about business or running a studio. And this was before there was such a thing as group reformer or any of that. And found a place in Sydney called Elixir, Elixr, which was in Park Street in the city. They're no longer there anymore, but they were a mind-body health club, and they had this amazing thing called Group Reformer, and they had yoga in there, and they had weights and cardio. Like, this was kind of like, whoa, this is kind of the place I want to open, except minus the weights and cardio and just with martial arts instead. So I became a member there, and I just used to hang out there all day because I had nothing better to do, and I was just teaching Kung Fu in the evenings, and so I just used to work out all day. And I got friendly with the owner because I used to hang out there all day as well, and he offered me a job, and I said, doing what? And he said, I don't know, we'll find you something. So I just started working there, and he trained me up in how to run a gym. I was very transparent with him. I told him about my goals to open my own space, and I became friends with the staff there, and one particular person, the manager there, she was in charge of running the Pilates training that they did. And one time we were sitting in the park across the road having a coffee, and she was telling me her problems, and the particular problem was that she had someone cancel out of a course and didn't have the minimum numbers go ahead, so she didn't want to look bad and lose face to the owner. So she said, pretty please, will you come and do the course on the weekend, do this Pilates course? And I was like, eye roll. Do I have to? And she was like, please, 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 please. And I was like, yeah, okay, but, don't forget you owe me a big favour. So anyway, I showed up for the course and was totally blown away. Was really surprised by how much I enjoyed it, and really haven't looked back a day since then. That was a mat work course. That was with Stop Pilates. Did the Reformer course. Did the Cadillac Chair and Barrels course. Did the Injuries and Special Populations course. Came back to Melbourne in 2006 when my wife and I were having a baby, and because my family lives here and a lot of her family does as well. And to open our own place, we opened our own place in Melbourne CBD called Breathe Wellbeing with 4 other partners. And it was just yoga and Pilates. By that time, we'd let go of the idea of martial arts. Continued to study, went across to Canada where the Stop Pilates headquarters is a bunch of times, I think 4 or 5 times to study there. Did all of their instructor trainer certification right up to the full Injuries and Special Populations. Trained in they're in Toronto, Ontario, Canada. Trained also on the west coast of the US. with their master trainer, Melanie Byford Young. And she really took me under her wing. We became great friends. My wife and daughter and I now, have a very special friendship with her and her husband, Kevin. And we go across and stay with them, probably every 2 or 3 years we go across and visit them. And we've spent a few New Year's Eves with them. So she really took me under her wing and mentored me quite a bit. I taught a bunch of courses, instructor courses with her. We started running instructor courses in Melbourne. When I was teaching, when we opened our studio, I was teaching, 25 classes a week for the first 4 or 5 years. And we had group reformer with 18 beds. We had group mat. We had yoga. I wasn't teaching yoga, but we had a whole bunch of teachers working with us. I ended up managing the studio for 9 years. We had an instructor program through Stop Pilates. In 2012, we split from Stop Pilates and did our own, created our own training. And that was because as I had progressed through training and it just become gradually dissatisfied with what I was teaching and really felt that there was more to offer the students in terms of more evidence-based approaches and more holistic education that included things like how to market yourself and how to, program a class and, how to work with pregnant clients and injured clients and things. We split from Stop Pilates 2012, and in 2016 I sold my share of the studio business to my partners. We had 2 studios by that stage, both in Melbourne CBD, and just took over, bought out the education business. And so since April 2016 I've been just teaching Pilates teachers. No longer own a studio, no longer teach Pilates. And I really feel like, at that stage I'd owned a studio for 10 years and I was really at a point of okay, I'm done. I feel like I've got no desire to own a Pilates studio anymore. And I think it's a fantastic thing and I'm really grateful for that period of my life, but I don't want to go back there because it doesn't inspire me as much now as teaching people to teach. I feel like I found my true happy place. My true passion is teaching movement, but not just, teaching clients movement, teaching people to teach movement. So, that's a long answer to a short question. Alicia says, "Hey, Raphael. I just have a question about nausea, queasiness, or feeling unwell after a Pilates session. I did some practice teaching with my family, and 2 ladies, both in their 60s or 70s, said they felt unwell and a bit queasy after my class. This was a beginner class with lots of layers. I'm just wondering if there's anything I can do or suggest for them, or will it subside over time as they get used to doing more movement? I told them to take breaks where they need to and move slowly between body positions and returning to standing. Thanks in advance, Alicia." Alicia, I don't think I've got a definitive answer for you in regard to nausea, but there are a few things that come to mind. The first one is probably vestibular, benign positional vertigo, basically, which is it's an inner ear condition where basically the inner ear senses position differently to what the eyes see, and so that discord between the inner ear position sense and the visual position sense causes vertigo, dizziness, and nausea, and that's what happens in seasickness as well. So if that is the case, it might help them to have their eyes closed in some exercises if there are particular positions that aggravate, and it might also be related to particular neck positions. So, maybe lying on their back with their head back, or, certain positions of the head, typically head back or to the side. So you might find that propping their head with a pillow or something to keep their head a bit flexed might help them. So, yeah, that's kind of my top of mind thought. The other thing is neck tension can be a cause of kind of migraines which have nausea as a component of their symptoms. This to me seems a little bit more of a stretch given what you've described, but it could be something. I mean, you could ask them about, how were their necks feeling after the session? Did their necks feel tight? If their necks felt tight, well, maybe just like things to help, just like a massage of their neck. If they could self-massage their neck, that might help. And if it is benign positional vertigo, actually, there are vestibular physiotherapists who specialise in the inner ear, who can probably help with that. So if that is the case, I would recommend consider going to see someone about that. And the final thing is maybe it might just be, like you suggest, kind of overexertion. Did they have gastrointestinal distress? Like, did they just have a big, heavy meal and half a litre of milk just before they did the class? Those are the other things that come to mind. So basically, if in terms of what you can modify, think about head position, maybe propping their heads, see if that helps. Do some neck strengthening work within tolerance, and see how you go. And I talked about some neck strengthening exercises in this Ask Me Anything not long ago in this very episode. So I hope that helps, Alicia. Let me know how you go. Peter says, hi, Raf. Would you be able to do an AMA blog post breakdown on what it can mean when a client says their lower back is tight, jammed up or seized up, and that it gets a little worse or more painful after exercise? Thank you. Yeah, Peter. Well, there was a fascinating study done, I think it was 2017, by Tasha Stanton, Lorimer Mosley et al. In Adelaide and they did it on this exact topic. So they basically had people come in who rated their low back as stiff. They had a subjective feeling of stiffness, what you're describing that your client says. And they asked them to rank their level of stiffness. I think it was out of 10 or 11 or whatever. And then they put them in this ingenious machine. Basically, they lay them on their tummy and put them in, sort of lock them in with these straps and things, and then got a machine that pushed on their back and measured how stiff their back was, measured how much resistance to movement there was in their back. And they had people who had self-described stiff back and people who didn't have self-described stiff backs. And what they found was there was no correlation between how stiff someone's back felt subjectively and how stiff it was when actually, objectively measured by, how much force it takes to move at a certain distance. But what they also found was, so the first thing there, the first finding suggests that the feeling of stiffness is not an indicator of actual stiffness. It's a subjective sensation, probably on the pain continuum. That is probably a protective mechanism. When you feel stiff, you don't move. You guard, essentially. It's a guarding response. So that's the first part. And the second part is that they found that the people who had higher self-rated stiffness were better at perceiving slight changes in the amount of pressure that the machine, applied to them. So the people with higher self-rated stiffness were more sensitive, basically. And so essentially, that suggests to me that this experience of subjective stiffness is really some variation of a persistent pain or protective nervous system sensitization type response, where the central nervous system, the brain and spinal cord, perceives heightened risk or danger, and goes into protection mode. Protects the body, and if you break your arm or hurt your arm, you protect it by not moving it, and if you perceive that your back is in danger, you protect it by not moving it. And that doesn't have to be a conscious choice. It can, most of the time, it's non-conscious. It just happens at the level of reflex. So that is what I would, that's how I would interpret that. People have a subjective perception of stiffness. That's a very real thing. They're not imagining it. They're not making it up. It's not psychological. It's a real phenomena. It exists, but it's not related to actual stiffness in the back. It's a protective mechanism that they perceive, probably non-consciously perceive, danger. And the best treatment for that is to get them moving and address all of the things that well, not all of the things, address some of the important things that contribute to increased central nervous system sensitization. And so some of the top, say, 3 to 5 things that might help these people are, number one, get them moving. And by that I mean, move the area, get them to do back bends, forward bends, twists, side bends. And I'm not talking about extreme wheel poses or anything like that. I'm talking about some cat stretch and some hip rolls and, just some nice movie type things. Whatever feels good. It doesn't have to be super gentle. It can be a workout, but just, it doesn't have to be extreme either. Just a normal, workout that moves the spine. And secondly, address sleep. Sleep is a massive factor when it comes to central nervous system pain sensitization. So get a good 8 to 9 hours of sleep. The best way to get 8 to 9 hours of sleep is to be in bed for 9 to 10 hours, because you don't fall asleep instantly, and sometimes you wake up in the middle of the night, whatever. So more time in bed equals more sleep as a general rule. Next one, address expectation. So their expectation, their beliefs around what's happening in their back. If they believe that their back is jammed up and seized, well, those are words that apply, would use to like a rusty motor or something, jammed up and seized. That implies it's mechanically malfunctioning. Well, actually, that's probably not what's happening inside their back. It's probably more happening inside their central nervous system, their brain and spinal cord, a perception of threat. It's not actually something that's happening inside their back, most probably. And so if you can help them shift that belief, and not by explaining to them that it's all in their head or anything, but simply by giving them positive movement experiences and not using words like jammed, seized up, but instead, when they say, "Oh, my back feels like it's jammed and seized up," you might, acknowledge that, but reflect it in a more benign way, saying like, "Oh, yeah, you've got some back discomfort at the moment. Your back's feeling a bit irritated at the moment." So, acknowledge their symptoms and their distress, but don't use words that imply damage or mechanical breakdown, because that's probably not what is happening in there. So that's what I would do. Thanks, Peter, and I hope that helps. Linda says, "Hi, Raphael. Question for you. What prevents a person from getting up off the floor from a kneeling lunge position? What muscles need strengthening to be able to push yourself up from this position, especially if you're getting older? It seems okay if holding on to something, but the use of arms is now involved, and to use the legs alone, the body just won't lift up off the floor." All right, and there's a second part to the question, which is also, what prevents people from stepping from a downward dog or an upside down V to a lunge and getting the foot in line with the hand and between the hands? Appreciate your help. All right, so let's answer the first question first, which is, what prevents a person from getting up off the floor from a kneeling lunge position? All right, so we're going to invoke the principle of specificity. So here's our person. They're in a kneeling lunge position. There's the floor. And they want to get up. All right, well, essentially, we could go through a whole list of muscles that are going to be, active in this movement. We could say, oh, it's the glutes, and it's the glutes, and it's the hamstrings, and it's the calves, and it's the quads, and it's the adductors, deep adductors, and on the rear leg, it's the hip flexors and the knee extensors, and we could go through all of that, and then I could give you a list of exercises to target each of those muscles, but that would not be the most effective way to do it. Because if you want to, the principle of specificity, this is a foundational principle in exercise and sports science, and what it says is exactly what you train is exactly what you get better at. All right, so if you want to get better at a thing, what should you train? Well, you should train that thing. For example, want to get better at middle splits? Spend time in a middle split. Want to get better at sprinting? Sprint. Want to get better at bench press? Do bench press. Want to get better at boxing? Practice boxing. Want to get better at yoga? Do yoga. Want to get better at swimming? Swim. So want to get better at standing up from the floor in a kneeling lunge? Well, guess what? Practice getting up from the floor from a kneeling lunge. Now, you said that the person can't get up without use of their hands. So I'm going to say, well, use their hands. You can either stand there and help, okay, a bit, not too much, or they could, hold on to the back of a chair. Okay, and then do, I would say, up and down, up and down. How many reps should they do? Well, until they almost can't do any more reps, I would say, if they can't get up and then they use their hand, let's say they do, I'm going to, give you a general number and say do maybe 8 to 10 reps per side, and do that 2 to 3 times a week. Now, if you want to do, or that will improve things, right? If you wanted to get, if they're keen enough and if they're motivated enough, and only if they're motivated enough, you could do 2 or 3 sets. So you could do your 8 to 10 reps per side. Then you could wait, say, 3 minutes, rest in between, and then you could do it again. And then you could wait 3 minutes, and then you could do it again. You could do up to 3 sets, and then you could do that 2 to 3 times a week. And what you will find is that within a couple of weeks, they won't need to use their hands. And then pretty soon after that, they will need to do more reps in order to get tired. So you could give them a couple of little dumbbells. Okay, take away the chair. Give them a couple of little dumbbells to hold on to. Okay, and now they're strengthening their legs. So if you want to get better at a thing, do that thing. Knowing which muscles is not the right question. How to strengthen it is do the thing. All right, also, what prevents people from stepping from a downward dog or an upside down V to a lunge and then getting the foot in line with the hand and between the hands? Well, let's have a look at that. So if you're in a down dog, wish my down dog looked like that, and then you want to step through into a lunge, bringing the leg through, swinging the leg through, requires you to go through this position here. So as you bring you're in your down dog, then, so let's start at the left-hand side here. So you're in your down dog, okay, and then you bring your hips down, okay, and you bring your leg through. Okay. Now, this position here requires you to lift your leg very much. It requires you to flex your hip a lot. And this angle in here between the leg and the torso is tiny. So it requires you to flex your hip a lot. And the problem that a lot of people have is two problems. Well, one, it's basically an inner range strength problem. So as you lift the leg in that position, there are two things that you've got to overcome. One is the gravity, the resistance of the leg, so just the weight of the leg. The second one is the stiffness of the tissues on the other side of the leg. So anytime you lift the leg, there's both the pull of gravity against the leg, plus there's the resistance of the muscles and the tendons and the fascia and the ligaments and all of the other bits and bobs on the back end of the leg that are stretching as you lift the leg up. So if the leg's heavy or if the tissues at the back are relatively stiff, that can prevent, and if the muscles at the front, the muscles that are lifting the leg up, are not sufficiently strong to overcome the combined weight and stiffness of the leg, well, you can't lift the leg high enough and it drags on the floor and you can't step through. So what you need to do is increase your ability to lift the leg up. And as we just talked through in the principle of specificity, if you want to get good at lifting your leg up, what you've got to practice is lifting your leg up. So here's what your friend can do, or whoever is having the problem. The first thing is you would stand maybe against a wall, okay, like a push-up, and you lift up this leg as high as you can with the knee bent, because that's basically the same position you're going to be doing in that step through to a lunge. And you lift up as high as you can, okay, and then hold it isometrically for just a couple of seconds and then relax back down. Do 8 to 10 reps. When that gets relatively easy, then you have to make it a little bit harder. And so then you simply change the relationship to gravity. And you do that by getting on a chair or something like that. Okay, you grab a chair. Okay, and you, instead of lifting your leg that way, now you're lifting your leg that way. And so that is harder because you've got more gravity to overcome. And then eventually you get rid of, when that gets easy-ish, you get rid of the chair and you go down to the floor. Bam. And there is, of course, by that stage, you have to be considerably better at doing this so that you can get the leg considerably higher, and you have to be able to get it up to there. So that is the progression that I would recommend, and I could list off which muscles you're strengthening. It's going to be predominantly psoas and iliacus, but that knowledge won't do you any good, because what you need to do is practice the precise movement that they want to get better at, and just do that in a graded way, that starting with their current capacity and building it up to where they need to be or where they want to be. Let me know how you go. Megan says, "Hi Raf, thanks for doing these informative Ask Me Anythings." My pleasure, Megan. "I have a new older client, and as I've been trying to teach his diaphragmatic breathing, I've realised his ribs expand on the inhale but don't funnel back down on the exhale. What could be causing this? I believe his shoulders seem relaxed away from his ears. All right. So there are a couple of things about that don't compute for me, Megan. So firstly, let's think about what diaphragmatic breathing is. All right. So in your torso, if we do your lumbar spine, here is your thoracic spine, here is your rib cage. Here's your pelvis, there's your sacrum. Looks like a pair of holly leaves there. All right, so your diaphragm muscle is essentially here. Like that. And your lungs are like that. And they are, believe it or not, essentially glued, attached to the top of the diaphragm. Now, when you inhale at rest, what happens is your diaphragm straightens out. It contracts. So it goes from a curved line to it shortens. It descends, okay? And so now it's contracted, it's got shorter, and the shortest distance between 2 points is a straight line. So now it pulls your lungs down because they're attached to it, and now your lungs are bigger. So your lungs are bigger, there's more space inside, so now the air inside your lungs takes up more space, so it's thinner. And so the pressure of the outside atmosphere is greater than the pressure inside your lungs, and so the pressure outside forces air rushes in to fill up that partial vacuum that you've created in your lungs by the diaphragm descending. And then when you want to breathe out, well, you relax your diaphragm, okay, and you, to a certain extent, the elastic recoil of your lungs and let me go back a step. So when your diaphragm descends, okay, it goes from here, okay, goes from there to there. Well, what's underneath the diaphragm is there's your spleen, there's your stomach, there's your liver, there's your small intestine, okay, there's your large intestine. Okay, so you've got all those, and there's a couple of other bits and bobs in there like kidneys and gallbladders and things like that. But, basically there's a bunch of stuff in there, and that's called your viscera. Your viscera, the bits inside you. And so when your diaphragm goes from that to that and pushes down, well, it pushes down, right? So it pushes your viscera down. And your viscera can't go down because there's a bone under them. There's a bone under them called your pelvis, and your pelvis is full of stuff as well, like your bladder and your uterus and muscles and things. So there's not space in the pelvis for the guts to descend into the pelvis. So the guts can't go down. So guess where they go? They go out. They go out. Okay. And so that is why when you breathe in through your diaphragm, your tummy puffs out. And if you sit or lie quietly and put a hand on your belly and take a deep breath into your belly, you're not actually breathing into your belly. You don't have lungs in your belly. But instead, your diaphragm is descending and pushing your viscera down into downwards, and they are displacing laterally. They can't get down further, so they spread out. All right, so diaphragmatic breathing then doesn't involve movement of the ribs. Really, it pretty much should involve almost no movement of the ribs. So when you're saying that your client is ribs expand on the inhale, well, that is a giveaway to me that he is not diaphragmatic breathing. So here's what diaphragmatic breathing looks like. Here's what non-diaphragmatic breathing looks like. So that's a chest breath, which is not a bad thing. It's just a chest breath. Here's a diaphragmatic breath. This hand doesn't move. This hand does move. So that could be a good exercise for you to do with him, is two hands there. Try and you can do this lying on his back with his knees bent in what's called crook lying. And so try and, for him to focus on not moving this hand, not moving his chest so his hand doesn't get pushed up, but moving, with his breath, the hand on the belly. And he'll probably be able to get that fairly quickly if you just let him lie there and muck around with it. So that's the first thing, is that if his chest is moving at all, it's really probably not diaphragmatic breathing. The second thing is that what you say is that his ribs expand on the inhale, but they don't funnel back down on the exhale. Well, to me, that doesn't compute, because if his ribs go up on the inhale, well, what happens next time he inhales? They go up more and more and more and more and more and more and more. They never come down, eventually float off. So they must be coming down. If they're going up and then he's subsequently able to take another breath afterwards, after exhaling, then they must be going down. So I would say it is happening. You're just not picking it up. And if his ribs are rising, he's not doing diaphragmatic breath correctly. So focus on moving the belly and keeping the ribs still. Hope that helps. Vicky Gallagher says, "Hi Raf, thanks very much for your podcast series. The content has been really interesting. I have a question about protein powder and its effectiveness. I recently went to a naturopath and they suggested getting more protein into my diet before workouts for muscles, and because my age, 40, as the body doesn't absorb nutrients as well as you age. They suggested I try a protein powder. I've started to add a protein vanilla powder to my yogurt and it's actually really nice. Anyway, my questions are more about what your thoughts are on taking protein powder and if its effect on muscles. I believe a lot of people will mix protein into a shake before they hit the gym or take it throughout their workout and afterwards. Do you think there is much to gain from doing this health-wise and to support muscle growth and recuperation, or is it really not that necessary and a bit of a fad? Thanks for your thoughts, Victoria." Vicky, no, I'm all for it. And that is because I've read the science, and the science strongly supports having adequate protein intake. So now, I'm not a dietitian and I can't give you advice about your specific diet, but here's what I know about the general research on protein, is that if you let's use our little tablet here. All right, so if you're in Australia, it doesn't really matter wherever you are, but basically the recommended daily intake, the RDI of protein for adults is 0.84 grams per kilogram of body weight. Okay, so if you are, just for the sake of ease, because 100 is a really nice round number, if you are a 100 kilogram person, okay, you should take, according to this research, 84 grams of protein per day. So 0.84 grams per kilogram per day. All right, so that is the recommended daily intake. So if you look up the Australian healthy eating guidelines, that's what you'll find. And if you look up the USDA ones, you'll find basically the same. However, if you are resistance training, if you're doing, reasonably strenuous strength training, whether that is Pilates or calisthenics-based stuff, or whether it's weights or, whatever it, CrossFit, whatever it is, if you're doing some kind of strenuous strength-based training, research has clearly shown that if you have up to 2 grams per kilogram of body weight per day, the more you have up to that amount, the more strength gains you get. So the better your muscles will respond, will recover, will grow and become stronger, up to 2 grams of protein per kilo of body weight per day. So if you were, again, a 100 kilogram person, you could take up to 200 grams of protein per day. Now, I have also read, in agreement with what your naturopath said, that for older people, now I'm not clear on how they define older, so I'm not sure if 40 counts as older, but I have read studies that found that for older people, even more protein can be beneficial because, like your naturopath said, absorption, the bioavailability essentially is less as we age. So I would even, if at 40 to me doesn't sound really older, so I'm not sure if this applies to you or not. Consult your dietitian. But if you were in your 60s, I would be thinking, maybe even 3 grams per kilogram per day. But again, you should go talk to a dietitian, and that's the best advice I can give you. But basically, it turns out that actually I am a 100 kilogram person. That's my exact body weight. And so I take 200 grams of protein per day. And it turned out that now we eat basically Mediterranean, so we eat mostly vegetables and legumes and olive oil and stuff, and we have a couple of times a week we have chicken or fish, but mostly it's vegetarian. We have nuts, we have tofu, we have all that kind of stuff, cheese, eggs, and I'm quite conscious of eating protein with every meal, and I tracked my protein for a few days and found that basically I'm having, just through my meals, I have well in excess of the RDI. I have about 100 grams of protein a day. So I have about half the maximum beneficial amount. I'm 49, so I reckon I'm starting to get into that older category. So I take a supplement. I just put some protein powder in a shake and have it 4 times a day, and I have a total of extra 120 grams just to be on the safe side. So that takes me up to about 220 per day. So as to whether you have it immediately after your workout or not, in terms of the nutritional factors that influence the success and effectiveness of your training, the number one factor is being a caloric surplus. If you're building muscle, you can't build muscle out of nothing. You have to build it out of something, so you have to have calories to build it out of. So you need to be in a caloric surplus to build muscle. The second thing is you need to have adequate protein. Adequate protein, as we just discussed, is up to 2 grams per kilo of body weight per day, or even more if you're older. I suspect you're not older, but go see a dietitian. They'll tell you for sure. And then, so those 2 things are the big, massive things. Right, and then other macronutrients. So have enough carbohydrates, so you've got enough energy to work out at the intensity that will get you better gains. So have enough carbohydrates, have enough protein, and then if you're doing all of that, you're doing about 80% or 90% of everything you need to do. Everything that's possible to do. Right, you're going to get the vast majority of your benefit from doing what I've just described. Then if you want to get super obsessive compulsive bodybuilder about it, you can start to time your protein intake and do it every 2 hours and have a 30-gram plus bolus of protein every 2 hours. And you can take advantage of the post-workout window, take protein within 40 minutes of finishing a strength session. But all of that timing stuff just adds 5% to the benefit. So really the biggest important thing you can do is have enough calories. The second biggest thing you can do, which is also really important, have up to 2 grams of protein per kilo of body weight per day. And if you can get that from food, so much the better, because then you'll get all the other nutrients that go along with it. And if you're eating plenty of food and plenty of good food and you're still not getting enough protein, because you can track your protein using an app like MyFitnessPal, or there's a whole bunch of apps you can find to just track your intake. If you're not getting enough protein, if you're not getting up to that 2 grams per kilo of body weight, then supplement with powder. Choose whichever one you like. There's lots of different ones you can buy, and basically whey protein, WHEY, whey, it's made from eggs, egg whites. Whey protein isolate is the most effective, and anything else like branched chain amino acids, blah 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 blah, not additional effectiveness, just additional money sucked out of your wallet. So have plenty of whey protein isolate lying around the house, and good luck to you. But really, go see a dietitian. I promise you it will be money well spent. Go see a sports dietitian, because that sounds like what you will benefit most from. Good luck. Hope that helps. Let me know how you go. Thank you very much. And that is it for Ask Me Anything for today, the 4th of September, 2020. Hope you found that helpful. If you have a question, I'd love to hear from you. You can email me. You can ping me on Slack if you're a Breathe Education student. And if you're not a Breathe Education student, I'd still love to hear from you. You don't need to buy anything off us. Send me your questions about anatomy, about physiology, about biomechanics, about strength training, and I will be glad to answer them. If I don't know the answer, which often I don't, I just go and look it up on Google Scholar and read a bunch of systematic reviews, and that allows me to extend my own knowledge. So you'll really be doing me a favour as well as yourself and everybody listening by sending in your questions. Thanks very much. Hope you're well. Hope your family's well. See you next week.